why is this important? As was mentioned at the start of the symposium, topic of cost came up, right? And so I mentioned Oncotype DX, which is the molecular-based test, the 21 gene expression panel from Genomic Health. And so one of the big advantages of a test like ibRis is the fact that it's orders of magnitude lower in cost, because you're only talking about the computational image analysis of a digital slide. The other piece, of course, is that it's very rapid, because you're not physically shipping tissue blocks from one place to the next. You're not destroying any tissue because you're just working off a digital image, and therefore could really have worldwide impact compared to the Oncotype, which is largely limited to the US. So in other words, you have an inexpensive, fast, reliable, accessible prognostic breast cancer test that is priceless for everything else there's MasterCard. Sorry, that's my feeble attempt at humor there. Several other examples I want to showcase very quickly in the interest of time. This is another area that we've been looking at, where we're using AI and computational pathology for risk stratification of DCIS, or ductal carcinoma in situ, which is what is called premalignancy or stage 0 breast cancer. The big problem in DCIS is knowing which of these DCIS would progress on to invasive ductal carcinoma versus those that would stay on as DCIS. Why is that important? It's important because the big question, certainly in the US, is how to treat these patients. Should you just treat them with surgery, or should you treat them with surgery and radiation therapy? If you knew in advance that these patients would progress to invasive breast cancer, then you want to give them radiation therapy. Otherwise, you don't want to give them radiation therapy. And so we've shown that looking again at features of the cells in these images, we are able to predict correctly as to which of these patients will progress on to invasive breast cancer versus patients who will not. Another problem that we're looking at is prostate cancer. Like I said, many men with prostate cancer will likely go on to get radical prostatectomy or surgery. Some subset of them will have a recurrence of the disease and therefore will benefit from chemotherapy. We've shown that looking at patterns relating to the shape of the individual glands and the arrangement of the glands on the pathology images of prostate cancer specimens, we're actually able to do a really nice job in separating out the patients who will have recurrence versus the patients who will not have recurrence. And we've just completed a study with almost 1,000 patients from 6 different sites. More critically, we also went head-to-head with a molecular-based test. I talked about the Oncotype DX test for breast cancer. Similarly, there's a test called Decipher, $3,000 test for prostate cancer in the US. When we went head-to-head with our image score with the Decipher test, there was non-inferiority. There was equivalence. The 2 tests performed just as well. But when we actually took the image features and coupled it with 2 very simple clinical parameters, we were actually able to show that we could do significantly better compared to this molecular-based test, suggesting that features like the ones that we're talking about, the image-based assays, potentially are not just competitive because they are lower cost, but they can actually be even more accurate compared to some of these molecular-based diagnostic tests. One of the other kinds of patterns that we've been very fascinated by is the concept of tumor-infiltrating lymphocytes. Now, TILs have really come into focus because of immunotherapy that I mentioned is one of these latest treatments that's currently being used for treating cancer patients. One of the things that we recognized is that the arrangement of cancer cells and immune cells is very different in patients who tend to do well, that is, don't have recurrence, versus patients who tend to have recurrence. And so in a paper that we published a couple of years ago, we showed that by using AI and machine learning to capture the unique spatial arrangement and interplay between the tumor-infiltrating lymphocytes and the cancer cells, we could distinguish which early-stage non-small cell lung cancer patients would go on to have recurrence. That is, they had poor prognosis, versus the patients who did well. That is, they did not have recurrence or had late recurrence. And again, you can see a very nice separation here between the 2 curves. We've taken the same approach, this concept of interplay between TILs and cancer cells, and demonstrated that these features are also predictive of response to immunotherapy in gynecologic cancers. We looked at endometrial, ovarian, and cervical cancers. I mentioned immunotherapy is really having changed the landscape of how we treat cancers today. The problem is immunotherapy is still imperfect. It only works about 20% of the time, 15% of the time. And it's also extremely expensive, something like $200,000 north of $200,000 per year per patient. And so when you think of a response rate of 15 to 20%, we really need better tools to know in advance as to which patients are truly going to respond to immunotherapy versus patients who will not. And so in this work that we presented at the ASCO meeting, we showed that these approaches, looking at the spatial interplay of immune cells and cancer cells, we actually could do a better job in risk stratification of which patients will respond to immunotherapy versus those patients who will not. I know that Dr. Patil has an interest in oropharyngeal cancers, so I had to talk about some of the work we're doing in head and neck cancers, where again, looking at the spatial interplay between immune cells and cancer cells in about 1,000 patients from 7 different sites, we've been able to demonstrate that we can tell which of these head and neck cancers will go on to have favorable survival, favorable outcome, and therefore could benefit from de-intensification of therapy versus those patients who are likely to do poorly and likely will need either the standard care or maybe even intensification of therapy. And in fact, what we've started to show now is that when you look at the different staging groups, if you look at stage 1, stage 2, stage 3 groups, when you look at the spatial interplay features of the immune cells coupled with multinucleation, which is another marker that we've been looking at, that we can actually start to provide prognostic information even within individual staging groups. And this again has significant implications for the way clinicians currently treat these different cancers. And it provides more information to the clinician in their ability to better tailor treatment for individual patients with head and neck cancer. A couple of things I want to just leave you with before I close. I've talked a lot about the features that we can get from the cancer, but what about looking outside the cancer? A couple of years ago, we showed in a paper that features and patterns coming from outside the area of prostate cancer turned out to be very important in predicting how the cancer did. So the features that were most relevant, in fact, didn't really come from the cancer itself. They came from the normal appearing area outside the cancer. So it's really important to consider where you're applying your AI, where you're applying your machine learning. Another question we've been trying to address is also, what are the differences between different populations? Do you use one AI model across different populations? Our results seem to suggest otherwise. In work we presented and published last year, we showed that when you looked at Black men and white men with prostate cancer, the appearance of the disease was actually quite different. Using AI, we were able to tease out differences in the appearance of disease in Black men, and therefore found that we had to create population-specific risk models for predicting the risk of recurrence in African American men. And so we recognize now that there are potentially differences at a cellular level that have to be accounted for when you're creating these AI models. In other words, one size is not going to fit all different populations, and you really may need to create very specific population-based risk assessment tools, just as we found now with our partnership with the Tata Cancer Center. In fact, in work that we presented just a few weeks ago at the San Antonio Breast Cancer meeting, we showed there were differences in breast cancer appearance in the phenotype of South Asian women as well as North American women, and demonstrated that, again, that you needed to create AI-specific models that were particularly geared towards the breast cancer phenotype for South Asian women, and sort of a standard model that didn't account for these differences would not work uniformly across different populations. So with that, let me conclude. Hopefully what I've conveyed is that computational analytics with routine imaging can help address questions in precision medicine. As was noted before, and I hopefully reiterated, the low-cost aspect of these tools is a really important consideration, particularly in low and middle-income countries like India, and that we really need to think about also potential differences in the disease phenotype between different populations, because it may suggest that we need to create dedicated AI-based models for different populations. I have to acknowledge, of course, the people who really do all the heavy lifting, who really do all the work,